So we come to our next session, which is management of hospitalized heart failure, reduced ejection fractions, case-based discussion on cardiac remodeling, and none other than Dr. Aftab Khan, who is a senior consultant, interventional cardiologist at the Apollo Clinicals Hospitals, to take it up with us.
Yeah, thank you. I would like to then get permission to share my screen.
Yeah, please.
Okay, are my slides visible?
Yeah.
Okay. Thank you for being here and giving me this opportunity to put in a few words here. So I think my topic of discussion is the management of hospitalized heart failure reduced ejection fraction patients. And I'll try to keep it a case-based discussion. And what we are trying to target here is the role of cardiac remodeling in patients with heart failure reduced ejection fraction. So when you talk about patients with heart failure reduced ejection fraction, I think we are all talking about patients who have an ejection fraction of less than 40%. And I think this differentiation is necessary because now we have these different heart failure criteria which have been set up. And we are also talking about patients who have heart failure with preserved ejection fraction, where the cutoffs are usually beyond 50%. So when you talk about patients with heart failure, we know that there's something known as cardiac remodeling that sets in. And this is what is the basic pathophysiology in patients with heart failure. And the various pathological and the physiological stimuli affect the cardiac tissues in multiple fashion. And when you're talking about the tissues, well, it's not only the cardiac tissues, we are not talking about the cardiomyocytes and the ventricular myocardium itself. We're also talking about the vascular smooth muscles and the endothelium. And all of this also has an effect in the way that the myocardium really works in terms of its pathophysiology and creating a patient with heart failure. We also understand that there's, in addition to the various macroscopic changes, there are cellular level changes also, and there's cell death or apoptosis, and of course the effect of RAS inhibition, the excessive beta blockade, the sympathetic overdrive, which also causes all these pathophysiological changes. We also need to understand that the event of left ejection fraction reduction eventually results from a change in the myocardial mass and the volume. So once we have LV dysfunction, there is a reduction in the LV mass, and there's also an increase in the LV volume because of the fact that there is retention of myocardial blood or inside the cavities. So when you have LV dysfunction, there is an increase in the left ventricular end systolic volume index and the end ventricular end diastolic index, along with a reduction in the left ventricular ejection fraction. And as I said, we all have studied from our days of physiology that it's a vicious cycle, and myocardial injury is only one of the pathophysiologies in this cycle or cascade, which involves multiple organs, which involves the sympathetic system, the nervous system, the renal system, as well as the myocardial system itself. So hypertrophy and reverse remodeling in heart failure is usually a manifestation, and that results, as we said earlier, in changes from the cardiac structure, from the myocardial composition, and also the vascular changes that happen inside the cells. And all of this affects the cardiac function and its reserve capacity. So once we start understanding the pathophysiological changes of myocardial remodeling, we know that this could be a target for us to make sure that we can improve the prognosis of our patients with heart failure and help them to live a better quality of life. This is a case scenario of a gentleman, an elderly patient with heart failure, reduced ejection fraction, who was recently hospitalized because of a heart failure event. And this is a gentleman who was initially doing well, but then he had a little difficulty in his activities of daily living. But then he had an episode of unconsciousness and was rushed to the hospital, where he was diagnosed with having a heart failure with reduced ejection fraction. His echo ejection fraction was 32%, way down from the 60% that we know is normal. His global longitudinal strain pattern was 15%, and his NT-proBNP, a marker of fluid retention, is sky high at 1,782. The echocardiography, which now is becoming the essential tool for us to assess these patients of heart failure and to differentiate between, as I said, heart failure reduced EF and heart failure preserved EF. Well, this gentleman, along with the reduced ejection fraction, had increased left ventricular end diastolic volume index, and left ventricular end systolic volume index and left atrial volume indexes. So all of these indicate that there is a poor LV contractility and an increased LV retention of blood in the various chambers. Well, this gentleman was hemodynamically stabilized, and then it was necessary for us to initiate the right therapy for him so that we can do something to improve his prognosis. And all of this prognosis is based on the ejection fraction. So cardiac remodeling and heart failure is now a major target of treatment with all our other drugs. And this remains a major factor in prognosis in patients with heart failure. And as I said, it's a vicious cycle. Once you have a myocyte damage and matrix damage due to a myocardial infarction, and this is the commonest cause of LV dysfunction in majority of the patients worldwide, ischemic heart disease and old myocardial infarction, and this produces a cardiac remodeling, which is often, as I said, interconnected with the excessive sympathetic overdrive, and along with the cell death, the fibrosis and the hypertrophy, which happens as a compensatory mechanism. And all of this results in an inappropriate remodeling and progressive aggravation or deterioration of LV function, eventually resulting in further deterioration of his LV function and presentation with heart failure. So three major criteria that we look at is the LV systolic function. We also look at the LV diastolic function, and we also look at the shape of the mitral valve, because all of this has a bearing on the filling of the ventricle as well as the total effective cardiac output. So left ventricular systolic function is something that is very easy for us to understand. A weak heart cannot pump adequately, or it cannot pump an enough amount of blood to maintain circulation to the peripheral system, even under conditions of increased stressors. So LVEF, or ejection fraction, is a common marker which is most commonly utilized, and I think an echo is the most common way that we look at our criteria of LV ejection fraction. We also look at LV end diastolic volume, or LV end diastolic dimensions, to understand the degree of systolic function and the degree of structural remodeling. Whereas left ventricular end systolic volume or left ventricular end systolic dimensions are the best way to understand what is the amount of systolic dysfunction. So when you have a patient who has a poor LV function and his left ventricle is less contractile, there will be an increased amount of volume that is left behind in the ventricle because the blood is not ejected out from the ventricle. The shape and the function of the mitral valve, or coming before that from the systolic function to the diastolic function, we also need to understand that the blood has to enter from the mitral valve, from the left atrium to the left ventricle across the mitral valve, and the left ventricle has to be receptive to receive the blood that has to come in from the left atrium. And in these patients, when there is a restrictive pattern, when there is myocardial damage, the left ventricular end diastolic pressure tends to be high. The ventricles are stiffer, and therefore there is a reduction in the mitral inflow. And this left ventricular diastolic dysfunction is something that reflects in a mitral inflow pattern, and this is often that of a restrictive inflow pattern, which is seen on an echocardiography as an E/A ratio, which is more than 2. And similarly, by means of looking at the mitral valve regurgitation, because there is an LV dysfunction, there is a dilatation of the mitral annulus, so there is a coaptation failure, which often results in a functional mitral regurgitation, or in patients with inferior wall MI, when there is a damage to the papillary muscle and the subvalvular tissues do not coapt well. So this also leads to an organic mitral valve disease. And both of this, the mitral valve annular dilatation, as well as ischemia of the papillary muscles, could contribute to an increased amount of mitral valve regurgitation, all of which compromises the functional flow or the forward flow, because when there is a contractility and with MR, there is more of a backward flow rather than a forward flow, which results in a lower amount of cardiac output. So cardiac remodeling is to be assessed, and this is something that we do by an echo, and especially when the patient is in the hospital. But again, what we need to understand that even in hospitalized patients, progression of an underlying cardiac disease with ventricular remodeling is an important cause of acute decompensated heart failure. And as we said earlier, our echocardiographers are very important in our decision-making planning process. They help us to guide the management, and it's important that we get a good echocardiographer to look at the echo and give us these small features. MR which is missed out, or a wall motion abnormality that is missed out, could make a difference in the way that we treat these patients. And again, these parameters, and not only the ejection fraction, because the ejection fraction is sometimes calculated in many machines, and it sometimes is a visual estimation by many people. But what we do is often look at the other parameters, as we said earlier. We look at parameters of systolic function. We look at the volumes, and we often mention the diastolic filling patterns also. Why it is important is that the remodeling patterns are not only assess or tell us about the event that has happened now, but they also predict the amount of CV events that are likely to happen in the future. So when you look at patients who have normal remodeling patterns versus patients who had concentric remodeling, eccentric remodeling, what we see is that patients who had a remodeling that has happened, and this is the black and the yellow, you can understand that patients, unlike patients who had normal events, normal echoes, we can see that all the events are much greater when there is a remodeling that takes place. And often the concentric hypertrophy is less dangerous than the eccentric hypertrophy that happens many times in patients who have an myocardial infarction. And again, to come back to this point of remodeling, the risk of CV deaths and heart failure hospitalization increases significantly, and the ejection fraction of less than 40% was studied. Candesartan, which is an ACE inhibitor, when it's an ARB rather, when candesartan was used in patients, and what we found is that patients who had an ejection fraction, even if it fell by less than 10%, and when there was a remodeling that took place, the outcomes were much worse. The cardiovascular death increased dramatically as compared to patients who did not have a poor ejection fraction or who had an ejection fraction which was closer to 40% as compared to patients who had an ejection fraction which was much lower than the 40% with remodeling. And similarly, as we said, the risk of heart failure, hospitalization, and death increases with an increase in the diastolic and the end systolic volume. Again, a small change in the end volume, which all indicate a poor ejection fraction, can all reflect in a higher mortality. So not only just hospitalization, we are looking at hard endpoints of even heart failure, death, and hospitalization that happens once there are changes in the LV end diastolic and end systolic volumes. And this has been proved in many studies. Therapy devices are devices that help to synchronize the heart by means of a device that is placed percutaneously. And what this does is that it helps to synchronize the heart. So once you achieve an AV synchrony or atrial ventricular synchrony, and you achieve a septal to a wall, lateral wall synchrony, what you do is that by remodeling or causing between these various chambers, you help the remodeling of the ventricle. So the ventricle, which otherwise would have bulged in one of the walls because of its contractility, once you give a stimulus and you help the wall to move synchronously with the septum, you often help in the remodeling that happens. And as a result of which, what we get is that once there is a remodeling or improvement in the remodeling that happens over a period of time, you can see that the mortality rates definitely come down. So when you look at patients over a period of time, as compared to patients with a degree of improvement in the ejection fraction. So here, as the ejection fraction improved, you see that there is a reduction in the mortality over a period of time. And this is then the same study showed that as you reduce the left ventricular and systolic volume, so as your ejection fraction improves, what would happen is that the systolic volume would reduce, the more blood is getting pumped out from the left ventricle. So once we see that over a period of time, as the left and systolic volume reduces, you see or a reduction in mortality. So as the left ventricular systolic volume increases, you see an increased mortality. Once the left ventricular systolic volume increases, you see that there is an improvement in mortality. So devices are, of course, a way to do that. But do we rush to put in devices in all these patients? The answer is no. And what we would do is to try optimal medical therapy. And do we have such therapies which work to help patients like these? Well, we know that over a period of time, we had ACE inhibitors and ARBs as our first-line drugs, along with the beta blockers. But now we have a molecule for almost close to 5 to 10 years now. And this is the army that we're talking about, the combination of sacubitril valsartan, which helps to improve cardiac remodeling. Well, are these drugs better than ACE inhibitors? And that's a question that we often ask because of the fact that these drugs are more expensive. And many of our patients are probably doing well on ACE inhibitors. And that's a question that all of us would think Is it worthwhile shifting a patient who's doing well now on ACE inhibitors and ARBs? Do I make a switch onto ARNI now? Well, the answer is that we have trials now which have shown and now they are the class 1 indication to be started over and above ACE inhibitors. There's a patient who's stable on ACE inhibitors and ARNI. I would still say that these patients should be switched over to an ARNI rather than leaving them on ACE inhibitors alone. What is the reason for this? The reason is that ARNIs are a combination of two drugs. So there's an ARB here, there's the combinations of them have different areas of action. So all of this, to cut short this of action, we know that there is a reduction in cardiac myocyte contractility, and all of this which happens in patients with heart failure, the remodeling is improved by use of these drugs. And therefore, this is the drug that I was talking about. And when there is a trial which has looked at head-to-head, so an ACE inhibitor ARB versus a sacubitril valsartan in patients with hospitalized. So there was initial concern that we should take use of these drugs only after the patient is stable, only after the patient gets discharged from the hospital. But now there's enough data to say that we do not wait to stabilize these patients on ACE inhibitors and then make the switch. We would say that now the guidelines suggest to start ARNI as early as possible in the patients who are even hospitalized. So we do not need to wait to stabilize them with an ACE inhibitor first and then switch to ARNI. We would start with an ARNI in the hospital. And this approach, as compared to an ACE inhibitor or an ARB, has resulted in an improvement of almost 7.5% in improvement in ejection fraction. And we know that each improvement in ejection fraction makes a difference. So an ejection fraction of 30% and an ejection fraction of 35 to 40%, but the patient who has an improved ejection fraction is likely to live much better and live longer. So not only is the quality of life better, his risks of having sudden cardiac death are also much lesser once the patients have an improvement in their ejection fraction. And the same study has also looked at the echo parameters also. And as I said, as compared to ACE inhibitors or ARBs, sacubitril valsartan had an improvement in the patient's end diastolic volume, end systolic volume, the left atrial volume, and the diastolic flow patterns. There's another parameter on an echo, and I believe that we may not be, so many of our people who have logged in may not be echocardiographers, but echocardiography has moved long ahead, and what we look at is also the global longitudinal strain pattern in patients when you're doing heart failure, and this strain pattern is used as a reliable and as an objective method to assess systolic function. So there's a spectral tracking that is done, and this provides an information on the segment. So I think this is again something that is more relevant to patients, to people who are doing echoes. But what we need is a parameter that you should also look at once you are treating a patient with heart failure. And the global longitudinal pattern helps in predicting mortality and readmission in the various studies. And again, as I said, this is again one more study where we looked at the global longitudinal strain, and they found that this is an independent predictor of heart failure hospitalization. Patients who had with a higher global longitudinal strain pattern had a higher risk of having heart failure readmission. Again, this is a study which had looked at reduction in the GLS, and it found that patients with on a follow-up sacubitril valsartan was much better significantly as compared to ACE and ARBs in reducing the global longitudinal strain patterns in patients with heart failure. So to summarize, I think what we need to understand that these patients of heart failure, we really have lots of choices. We now have ARNIs. We also know that beta blockers. We also have the corticosteroid antagonists, and we now also have SGLT2 inhibitors. So one needs to understand that with this armament that we now have, hospitalized patients with reduced ejection fraction with an impaired, as I said, LV dysfunction in this group of patients, it's important that we start using these drugs in an early course of our disease. We do not wait till the LV function really deteriorates. ARNI, for instance, has proven to its benefit with multiple, there have been multiple controlled trials which have been done, and these are now class 1 indications or the first line therapies in patients in ACC as well as the ESC consensus guidelines. Thank you for your patient hearing, and I'll stop here and take questions if there are any.
Thank you, Dr. Khan, for your deliberation. I'll just come back to you with a couple of questions after a brief video.
Hello and welcome to this year's NDAP Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference. It is excellent in the sense that all the topics has been so nicely selected that they are very practical, and I'm sure all the delegates would be able to utilize what they are studying or what they're reading or what they're understanding from these topics, and they can apply that the next day when they go to their hospital or their respective clinics. There has been a very good, nice choice of speakers who are doyens in their respective field to address this issue. So don't miss it, ladies and gentlemen, and welcome once again.
Dr. Khan, thank you so very much. And there's just one question which is there in the chat box, but I think it will take you some time to answer. Till the emperor preserved, we had nothing for heart failure preserved ejection fraction. And Paragon heart failure kept side by side, perhaps fell a wee bit short of the results desired for. So in a patient with heart failure preserved ejection fraction between 50 and 60%, keeping the Paragon heart failure and the Emperor preserved trial in mind, what would be your initial choice of anti-heart failure therapy?
Yeah, I think this is a tough question. I think itself it requires another lecture when you talk about heart failure preserved ejection fraction. So unlike the heart failure reduced ejection fraction, where, as I said, we now have drugs in our armamentarium. We now have these big four, the ARNIs, we have the MRAs, beta blockers, and the SGLT2 inhibitors. I think in the patients with heart failure preserved EF, we are still not looking as good as we would probably be doing a few years back. But I think what is most important for us is to realize that these patients with heart failure reduced ejection fraction with patients with preserved ejection fraction, these are two different subsets of patients. So preserved ejection fraction, usually in the reduced ejection fraction, I think it's very simple. You have LV dysfunction, you have an MI, you have these patients who have a scar on the ECG or on the echo, and you know what to do with them. Whereas these patients with preserved ejection fraction are patients who are usually more elderly. They're the hypertensive, they're the patients with CKD, they're the patients who have arrhythmias, and these are the patients who have atrial fibrillation more commonly. So these are the patients where sometimes the treatment of the primary pathology also plays an equally important role. So when you have atrial fibrillation and patients with preserved ejection fraction, well, as we know that in patients with LV dysfunction, the atrial fibrillation does worsen the arrhythmia, does worsen the heart failure, but equally so in patients with preserved ejection fraction. I think we also need to set our targets to treat the associated comorbidities. So treating your renal failure, treating your arrhythmias, treating your anemia, all this becomes more important. Well, coming back to the tools that we have, again, I think as you said very clearly, Dr. Roy, we are still in the dark. I think diuretics still play the major bulk of our treatment protocols and patients to decongest them or treat them with symptomatic. We now have something to grope onto. And of course, as I said, we do have some data from the Emperor preserved, as you said, the SGLT2 inhibitors can be used in this group of patients. ARNI also, as there have been studies where we have seen that a particular subset of patients with ARNI, and especially the women, where probably in the preserved EF you may still have a benefit. Again, the subgroup analysis of these studies have showed that in a particular subset of patients with an ejection fraction that is beyond 57%, you could still have some benefit of this ARNI. But do I start with these patients with ARNI as the first line? The answer is no. So as much as my confidence is in patients with reduced ejection fraction, well, in the patients with preserved ejection fraction, I think we still have to have a clear discussion with the patient. These are drugs that are expensive. These are drugs that often we use with some conviction. And I think it's important that we discuss with the patient, tell them that the data is limited, and these are sometimes drugs we do try once the patient agrees, but we often have to understand that the associated comorbidities are sometimes easier to treat and get more benefit rather than looking for a magic pill.
Yeah, I totally agree with you. And I think that the time has come that we particularly disseminate knowledge about how to diagnose heart failure preserved ejection fraction.
Right.
Yeah, because that is very important. More than because we have limited choices, diuretics would give you symptomatic relief. Yes, at times it's difficult for us to treat the comorbidities to a satisfactory level that might take care of the heart failure. Thank you so very much. Again, taking the patient into confidence becomes important. Sharing the data with them becomes important. And thank you for sharing your time with us and your expertise. Thank you so very much. We loved it.
Thank you for being here.